Thank you. How many people were here yesterday? Most of you, good. Then a lot of foundational stuff I don't have to talk about so much. Little bit for the new people. First of all, Steve, thank you for introducing me as a friend, because not every place I go do they think I'm a friend. If this were a conference of pharmaceutical representatives, they don't think I'm such a friend. Big food companies don't like me so much either. But anyway, thank you so much for coming again to hear what I have to say. I'm Pam Popper from Columbus, Ohio, and I'm president and founder of Wellness Forum Health and the Wellness Forum Institute for Health Studies, which is a school that we started in 2009 because we feel that there's a lot lacking in health professional education, and we're trying to change that. Our main goal in our main service that we offer is informed medical decision making, which means that consumers should have full knowledge of the risks and benefits of anything they're thinking of doing related to diet and health. That includes diet, supplements, screening tests, diagnostic tests, drugs, procedures, before they make a decision. The reality is, and a lot of times in my office, what we're doing is we're looking retrospectively back at what people have done and figuring out if certain things were a good idea or a bad idea, and then trying to do better coming forward. And people sometimes say, gosh, Pam, you're so lucky. You're in the prevention field. I have to tell you something. The horse is out of the barn. We're not in the prevention field. We're in the fixing field. Most of the people in this country are sick. Most of the people in this country who are adults are taking drugs. And by the time they're my age, I'm 61, they're taking lots of drugs. So I'd love to be in the prevention business, but I probably spend 11 minutes a week on prevention, and the rest of it we spend solving the mess that gets made when you have a combination of consumers who don't understand what they need to do to take care of their health, practitioners who are poorly trained and don't read the medical literature and don't know what to do and what to advise people about how to take care of their health. That's the mess that we're trying to clean up. And I think it's a fixable situation. I think the fact that this conference keeps growing every time it's put on is an indication that Americans want things to be better. Everybody all over the world wants things to be better. And I'll say for the record, I get sick and tired of hearing about when people complain about these slothful Americans that don't care about their health, and they aren't willing to work at health, and they don't want to eat better, and they just want to take a pill. There's some people like that. But I don't think that Americans who don't care about their health, I don't think that those are the type of people who are spending millions of dollars on diet programs and books and going from doctor to doctor looking for solutions. I see the opposite. I think people really are seeking health. And I've told many health professionals, this is why I'm such a popular girl, I've said, what you're doing is you're pointing the finger at other people as a way of deflecting attention toward your own shortcomings, and I really think it's abominable. So anyway, these types of audiences, you people care about your health, and that's what I love about coming to this type of a conference, is that there's so much good feedback and questions, and I think there's more of this all over the country. There are people who want to be well. Now we just have to spread the word about how to do it. So today we're going to talk about gastrointestinal disorders, and this is a good topic to talk about because so much of the rest of your health is dependent upon the health of your GI tract. I'll just start by telling you that eating and digestion and elimination are not supposed to cause all kinds of discomfort. I mean, you have to think about it. How could humans have ever survived back in the day when we were hunter-gatherers and cave dwellers if every time we ate a meal we became constipated or had diarrhea or we had reflux? I mean, we'd be so distracted by our GI symptoms we never could have outrun the animals chasing us and managed to survive. This is not supposed to be the way things are. Pain, gas, bloating, heartburn, constipation, these are all signs of a poor diet, but they're very common. This is one of the problems we face today, is the fact that so many people are sick and miserable that being sick and miserable has become the norm, and people don't any longer think that it's a real problem. And if you turn on the television, I watch some TV, not very much compared to many people, but I don't think you can watch television for a half hour without seeing some type of advertisement for a drug or a supplement that is designed to address gastrointestinal distress. So that's a sign that a lot of people are doing a lot of things wrong. So this all begins in the gut. The surface of the digestive mucosa, measuring up and down and around all the folds, villi and microvilli, is about the size of a tennis court. Think about how big that is. That is what the surface of the intestinal mucosa looks like. We actually started looking at the gut bacteria as having some significance back in the early 20th century. Eli Metchnikoff won the Nobel Prize, and he was the first person to suggest that there was such a thing as beneficial bacteria in our gut that might help us stay healthy. In fact, there are about 1,200 types of bacteria in our digestive tract, 100 trillion bacteria down there. And to put that in perspective, there are 37 trillion bacteria, or 37 trillion cells that make up the entire human body, and 100 trillion in our gut. So there are more of them than there are of us. And the two most important are lactobacillus and bifidobacteria. So what do these bacteria do? Well, they produce tiny amounts of some vitamins like vitamin K, short-chain fatty acids. They create an acidic environment that's pretty hostile for pathogenic bacteria. They assist in digestion and nutrient assimilation. They provide protective barrier to entry into the bloodstream. They regulate immune function, and they help to regulate mood through the production of neurotransmitters like serotonin and melatonin. And isn't it interesting that psychiatrists are so focused on chemical imbalances in the brain, when actually we should be focused on the production of those neurotransmitters in the gut? That's where all the action is. So, yeah, well, we definitely should not be concentrating on chemical imbalances in the brain since there isn't any such thing. In some branches of medicine, we just make stuff up. What can I say? All right, so where does this bacteria come from? Well, the origin is actually in the placenta. We didn't used to know this until recently, but it's about 10% bacteria by mass, and there are about 300 different types of bacteria. And it wasn't so long ago, actually, that we discovered that this bacteria survives and the baby has some of it in his mouth and in his gut after being born. Another way in which infants or humans acquire the bacteria is through vaginal delivery. And in fact, the colonies of bacteria in the vagina start increasing in the third trimester in anticipation of a vaginal birth. Infants born via C-section acquire their bacteria from the hospital environment, which, as you might imagine, is not quite as good as acquiring it from mom. So the really good transmission of bacteria, the way nature intended it, is done through vaginal birth. Babies born via C-section, their microbiomes are different. They have much slower development of beneficial bacteria and higher levels of pathogenic bacteria like C. diff. These differences are sustained. By the age of 7, most kids still have big differences between the vaginally born and the C-section babies. Now, let me say this for the record. I think C-section births are sometimes the thing to do to save the baby's life or the mother's life. We just do way too much of it here. It's an elective procedure in too many cases. 30% of the, we have the highest rate, I should say, of C-section births in this country in any place in the world. One of the problems is we do it too often, convenience of the doctor, convenience of the mom. The other thing is the myth that if you've had one C-section birth, you must now have all C-section births, which is not true. Women who've had a C-section birth can vaginally deliver a child. Breast milk is the next thing, and there was some conversation about breast milk when Dr. Campbell lectured yesterday during the Q&A. So breast milk seeds the bacterial colonies. And actually, colostrum, which is the first thing that comes out of the breast, has really dense bacterial diversity. The composition of bacteria in milk is very different depending on the health of the mother. So there's a lot of data on this, but I'll just pick one example. Again, this is stuff where I have like 25, 30 hours of lecture, and I'm trying to condense it here. So just one example is the composition of the bacteria in the milk of a mother with a higher BMI is different than a normal weight mom. There's also a difference in the bacterial composition of the milk for the mom, depending upon whether she delivered the baby via C-section or vaginally. Milk samples from moms who delivered via non-elective C-section showed bacterial composition close to the milk of the mother who delivered via vaginal delivery. So what I'm saying is that in nature's perfect plan, the body seems to know if the C-section was warranted or not. If it's warranted, the body makes adjustments and says, it's not mom's fault. So we are therefore going to make arrangements to change the composition of the breast milk in order to make up for what was lost by not having a vaginal delivery. And I think this is a great example of the fact that we don't have enough respect for nature's perfect plan. There is a perfect plan. It's how we survive to be able to be in the same room today and have this conversation. Breast milk contains a prebiotic, several types of prebiotics and oligosaccharides that promote the growth of beneficial bacteria like bifidobacterium. And one of the reasons why we see a high concentration of bifidobacterium in the infant and toddler's gut is it inhibits the growth of pathogenic bacteria, promotes a really good thick lining of the mucosal barrier, reduces inflammation. Infant formula containing probiotics promotes the gut microbiome some, but it's not a substitute for the rest of it. So we keep thinking that because we're so smart as humans, we're somehow going to be able to duplicate nature. There's really no duplicating nature. Breastfed infants have a lower colonic pH, and what that is important for is low colonic pH results in an environment that's real hostile for the pathogenic bacteria. It keeps the colonies in check. They have a higher concentration of fecal acetate than formula-fed or infants fed both breast milk and formula. Bifidobacteria, the good bacteria, produce acetate. It's an anti-inflammatory substance and it protects against pathogens. Just one bottle of formula per day during the first few weeks of life can shift the microbiome to higher levels of pro-inflammatory bacteria and lower levels of acetate. Again, we can't fool Mother Nature. There was a commercial. Some of you might be old enough to remember this commercial on TV. They used to say it's not nice to fool Mother Nature. And I think it was promoting butter. Not such a good thing to promote, but the point was well taken, right? It's not nice to fool Mother Nature. Using formula with breast milk diminishes the benefit of breast milk. It alters the structure, quality, and quantity of the microbiome. Formula feeding allows for bigger increases in C. difficile and other pathogenic bacteria and decreases the bifidobacteria content. If the baby is formula fed, obviously you're going to end up with a different microbiome. And you can measure it at 7 days and at 19 weeks. And what you see is by 19 weeks, there's a little bit of catching up. But again, if you go all the way out to 7 years, you'll see that it never is quite the same as if the baby was vaginally born and breastfed. So consequently, babies that are breastfed and C-section birth or both should take probiotics. And you can give probiotics to a baby. Basically, you get a powdered probiotic. The mother licks her little fingers and puts it in the well and sticks it in the baby's mouth. And I'm going to knock on wood here. We've never had a baby that refused to suck the bacteria off of the mom's finger. They think it tastes good, which is good. Maybe they instinctively know it's good for them. And so we recommend this. And by the way, sometimes the vaginal birth and breastfeeding thing isn't an option when parents adopt babies, for example. So our parents who are members of Wellness Forum Health are pretty well trained, and one of the first things they'll do when they adopt a baby is say, I need to come by and get some probiotics for this little kid because we're not exactly sure about the birthing, and we know this baby wasn't breastfed because we got it when it was a few weeks old or even a few days old. So that's one of the ways that you can protect some. And we have some really good studies that have shown that probiotics for kids like this make a difference. And we also have some studies showing that even vaginally born breastfed kids benefit from taking probiotics. They get a little fewer infections, less colds, flu, that sort of thing. All right, so that's how you get your bacteria. Now let's move on to how you can protect your bacterial, your colonies. The composition of the diet affects the diversity of the gut bacteria and its composition itself. Microflora thrives on partially digested food remnants. So if you want to feed the beneficial bacteria, they really like carbohydrate and fiber. They require 250 calories worth of carbohydrate every day. Changes in the ratio of beneficial to bad bacteria, pathogenic bacteria, start within 2 weeks of changing your diet one direction or the other. So if you change your diet in favor of eating a more plant-based diet, within a couple of weeks you start to see shifts. If you decide after leaving here you're going to go home and eat cheeseburgers and french fries, within a couple of weeks you're going to see some negative changes in your gut microbiome. Fiber and indigestible sugars provide food for the beneficial bacteria, and there's only 2 places you can get this stuff, and that is breast milk and carbohydrate plant foods. Vegetarians have higher counts of beneficial bacteria than non-vegetarians, and the guts of Africans who eat high-fiber diets are quite different than the guts of Europeans, for example, who eat high-fat diets. Animal foods, and you heard Dr. Esselstyn talk about this both last night and during his lecture, can injure blood vessels via interaction with the gut microbiome. So intestinal bacteria metabolize lecithin and carnitine from animal foods and turn it into a substance called TMAO. It promotes vascular injury. Increased levels of plasma TMAO were associated with a 2.5 times increased risk of cardiovascular events, even after adjustment for other risk factors like hypertension and smoking. People who consume a plant-based diet manufacture TMAO, even if they go crazy and eat steaks and take carnitine supplements. So if I were to go out to dinner tonight and eat a great big juicy steak, I still don't produce TMAO because I don't have the bacteria in my gut that will produce it. But guess what? If I just keep eating steak and cheese and chicken breast and all that sort of thing, within a couple of weeks, my bacterial colonies will start to respond, and I will have the necessary bacteria to injure my endothelial tissue with this TMAO. Very seldom do you see in the medical literature comparisons of vegans, legitimate comparisons of vegans, and one of the reasons is it's hard to find vegans to do a study with because so many vegans they've stopped eating animal foods, but they're not necessarily eating an optimal diet. And that's one of the things we have a little bit of work to do, and I did this, by the way, in the beginning. When I first changed my diet and started eating a plant-based diet, I think I gained 10 pounds, and the reason was I was eating vegan Oreos and vegan chicken nuggets and vegan this and vegan that, and I had just managed to duplicate my terrible dietary pattern at Whole Foods, okay? Well, the first thing was that if I kept going that way, I was going to have to put a mortgage on my house because it's ridiculously expensive to eat this way, but I wasn't seeing the health changes. So anyway, once in a while, you'll see a study that actually compares healthy vegans to others, and this was a study of Slovenian vegans. They had more beneficial bacteria in their microbiome, which were involved in lowering inflammation. And these are the bacteria that thrive on fiber. Fecal samples from vegans have lower pH than controls. Remember, that low pH environment is what makes the pathogens really nervous and difficult to survive. It leads to, and one example is like E. coli. For some reason, we all have some of these pathogenic bacteria in our guts, a little bit of E. coli, a little bit of C. diff, but when those populations are kept really low, they don't cause problems. So the example I always use for people is how many people dust the furniture in their house? And then even after you dust it, if you look at it just right in the sun, there's still a little bit of dust. Okay, so no matter how much you dust, there's a little bit of dust, but if you stop dusting at all, you end up having to move out of your house, right? So you're always going to have a little bit of dust in your house, and you're always going to have a little bit of pathogens in your gut. You just want to keep the population under control. And I like this quote from the study. The vegan gut profile appears to be unique in several characteristics, including a reduced abundance of pathobionts and a greater abundance of protective species. Reduced levels of inflammation may be the key feature linking the vegan gut microbiota with protective health benefits. All right, it doesn't get much more clear than that. All right. So it's important to protect your gut bacteria. Gut health is related to everything else. And so we could spend all day on diseases related to the gut. Here are some of the common ones, and this is why I have like 25 or 30 hours of lectures. But bad breath, skin disorders, constipation, iron deficiency, reflux, asthma. People don't usually link asthma as being a gut disease, but it is related to gut health. Failure to thrive, depression, anxiety. You can see the list here. It's pretty big. So let's talk about, we'll come back to some of those diseases, but let's talk about colon cancer, which is a disease of the gut. And it all starts with the development of polyps. 35% of Americans have them at some point in time. And by the way, polyps can develop any place in the body where there's a smooth mucosal surface. So you can get polyps in your sinus passages, for example. They're developed in response to chronic irritation. Diet contributes because diet is the thing that can irritate in many ways. So the size of the polyp is determined by the amount and length of time of irritation. It starts with irritation, and then eventually you get cell proliferation, and then at some point in time you develop a polyp, and cancer can develop from that. Polyps less than 5 millimeters, not likely to become cancerous. By the time they're 10 millimeters, 1% will become cancerous. 20 millimeters, 17% become cancerous. Here's how you can stop them from becoming cancerous. Stop irritating them, right? I mean, if I had a big sore on my arm and it was bleeding all over the floor and I stood up here and picked at it telling you my arm wouldn't heal, what would you tell me? Stop picking at the sore, right? This just makes sense. So the way that you stop the development of these polyps is you stop irritating them. And by the way, it takes a long time for this to happen. In other words, you don't eat bad food and the polyp develops and becomes cancerous. It takes years for this to happen. So those of you who have not had colon cancer, thankfully, you can keep yourselves from getting it by adopting the right kind of diet. Well, here's part of where the irritation comes from. Animal foods contain high levels of sulfur-containing amino acids, which produce something called hydrogen sulfide. It's a god-awful substance that lowers mucus production, and if you have less mucus in the lining of the colon, it can lead to irritation and the development of polyps. A high-fat diet adds to the mess by increasing the production of bile acids, which are converted into cancer-promoting substances by the bowel bacteria. Low-fiber intake allows the irritating remnants of animal foods to stay in the colon longer, which compounds the problem even more. And so it's not surprising that today colorectal cancer is the second leading cause of death in the United States. So what we're all told to do is early detection is the key. Yes? That's what we're all told to do. We should have screening so that we find the cancer early. Well, according to one study, colonoscopy misses all polyps and cancers on the right side of the colon, where about 40% of the cancers develop. Instead of preventing 90% of cancers, the real number is something like 60 to 70% of cancers. Colonoscopy is not better than sigmoidoscopy. Sigmoidoscopy examines the left side of the colon, colonoscopy the entire colon, and sometimes the way that medical practices get started is they are based on the idea that more is better. We talked about this yesterday. If a little bit of calcium is good for you, then taking as much as you can swallow in a day must be better. So if sigmoidoscopy is good, if we can come up with something that investigates the entire colon, that must be better. Well, there's quite a bit of research that has shown that this hasn't been the case. Researchers analyzed 3 studies and found that colonoscopy did not reduce the death rate from colon cancer more than sigmoidoscopy, but it's significantly more invasive. And I think the quote from this study is worth reading. It's disconcerting to realize that 20 years have passed since we first started using colonoscopy for screening, and we still don't have adequate data to back the long-held belief that it's superior to other methods. If further studies continue to find that colonoscopy is not an improvement, we should be prepared to consider returning to sigmoidoscopy for screening while we explore ways to enhance colonoscopy's effectiveness. And I think if anything shows the fact that informed decision-making is necessary by all, it's looking at this type of information. The colonoscopy is the gold standard. Everybody's told they should do it at a certain age. Actually, we're not quite so sure that that's true. And I think that you should at least have this type of information before you make a decision about whether or not to have this screening test. This will shock you, but not one randomized controlled trial shows that colonoscopy reduces the risk of dying of colon cancer. Serious complications occur in 5 out of 1,000 procedures, and perforation occurs 1 out of 1,000 times. 1,250 people have to have a colonoscopy to save one life, and for every life saved, one person is harmed or dies from a complication of the procedure. So we save one, hurt one, or maybe kill one. Now, again, I don't think it's for me to say you should or shouldn't have a colonoscopy. I think it should be a standard practice in medicine that the person has this information before they make a decision, all right? In 2016, the Canadian Task Force on Preventive Healthcare, that's sort of like our U.S. Preventive Services Task Force, updated its recommendation for colon cancer screening, and I will read to you from the guideline. Does not recommend using colonoscopy as a primary screening test for colorectal cancer due to lack of evidence. The recommendation is for fecal occult blood test or fecal immunochemical test every 2 years for adults between 60 and 74, or every 10 years with flexible sigmoidoscopy. In other words, no testing for people under the age of 60. Now, I'm not too crazy about the fecal occult blood test, but there is a pretty good body of evidence for the home stool test, which is the FIT test. Requires no liquids to clean out. There are black box warnings on the liquids used to clean out the colon. No anesthesia, almost no risk. By the way, when this test started, when research started coming out on the FIT test, there was even some chatter on Medscape and Medline that maybe we should start promoting this because it's so much easier to get people to do this than it is to get a colonoscopy, even aside from the efficacy rates. In spite of the fact that Katie Couric had her colonoscopy on television and all that sort of thing. First of all, it's the shameful use of celebrities to promote bad ideas, and then shame on the public for thinking that because Katie Couric did it, we should all do it. In fact, I have a general rule of thumb. If a celebrity's doing it, I probably shouldn't be doing it. That's sort of my own rule. I've never understood why everybody wanted to be like people on TV because, I just don't understand that. Let's leave it at that. So decision about the test should be based on patient medical history, a conversation with the doctor. But basically, I won't read you this quote, but what this group of researchers said is that as a screening tool, colonoscopy doesn't have much use. As a confirmation tool based on a suspicious screening test, it may have some value. We're just doing too much of it. And I mentioned, I think, a couple of times yesterday that most of what we do in medicine has some usefulness. It's the abuse of the practice and trying to broaden the usefulness to populations that can't benefit that is causing a lot of our problems, and that's what we really should stop doing. Now, that brings me to, people say, well, why do you focus on all this other stuff? First of all, because my business is informed medical decision making, but the second thing is I want people to change their diet. And one of the downsides of screening tests like colonoscopy is it encourages people to think that they can eat, drink, and be merry, and go have a colonoscopy and a PSA test and a mammogram and all the other things they want to do to you, and then we're going to catch everything early. And so what ends up, the dynamic that ends up happening that I really don't like is people think because their test results are good, even though the false positive rate's terrible and all that sort of thing, that what they say to themselves is, I got away with it. I can go home and sit on the couch and eat McDonald's and continue to eat cheese, and then I'll have another test next year to see if I'm still getting away with it. Well, I want people to change their diet. So this type of information that I'm putting in front of you has an incredible effect on getting people to the place where they're ready to say, you know what, that diet's looking better and better and better, because as it turns out, this other stuff that they're telling me to do instead of diet, it isn't all that effective for most people. So the best option for preventing colon cancer is a low-fat, high-fiber, plant-based diet. Patients with chronic constipation, which is just one consequence of eating a terrible diet, are significantly more likely to develop colorectal cancer than patients who aren't constipated, and it's a dose-dependent effect. The more constipated you are, the higher the risk becomes. And that's just, as I said earlier, slower movement of waste through the body gives additional exposure in the colon for longer periods of time to the toxic substances that cause the irritation. So those of you who've adopted a plant-based diet already know it's a moving experience, right? And the moving experience usually starts pretty early on, and and isn't it interesting? We're a group of people who don't mind talking about the moving experience, right? Everybody else considers it so embarrassing and all that. I'll never forget one of my top people at my company who's been with me forever. The first couple of weeks that she worked in our office, she came into my office one day and sat down. I said, "What's up?" She goes, "You people talk about bowel movements a lot here." I said, "Yeah, we do." She goes, "Really? Is it always like this?" I said, "Yeah, pretty much." And now she talks about bowel movements too. It's amazing how conditioned you can become to knowing that this is just a human function we should pay attention to. All right, well, if we're going to talk about gastrointestinal conditions, we can't ignore reflux because, again, if you watch television and you see the ads for proton pump inhibitors, and I hate those ads. They make me so angry I want to throw my shoe at the television set. It's the one thing that may make me cancel cable, all right, because they show these overweight people eating garbage, right? And so you take your purple pill, you go eat fried chicken, and woohoo, you feel fine. And it's just the worst message possible. I mean, it's good news about your bad habits if you're watching TV and looking for a way to keep eating fried chicken, but it's just a terrible message in general. All right, so gastroesophageal reflux disease. What happens here is the lower esophageal sphincter relaxes when we swallow food to allow it into the stomach and then closes. The GERD results when that sphincter opens and closes at the wrong times. There are two primary causes. You can have some structural damage to the LES resulting from poor diet and the constipation that is a consequence of the poor diet. In some susceptible people, the LES can transiently relax in the presence of some foods. So there are food triggers for people, and we sometimes have to look beyond just the adoption of a plant-based diet in resolving GERD. Stomach acid and other contents then come up into the esophagus, and that's what causes all that burning and pain. It's diagnosed mainly through symptoms and sometimes endoscopy, although endoscopy doesn't always confirm it. Increasingly, though, people are self-diagnosing and buying proton and pump inhibitors on their own. You can go to the store and buy them without a prescription. And I just wrote a 5-page article, and one of my video clips this week was on proton pump inhibitors and the fact that they really don't reduce your risk of dying of esophageal cancer or developing it at all. And they often induce a worsening condition. In other words, when people stop taking them, their acid production increases exponentially. And so we have to withdraw people from PPIs very carefully because they could be quite miserable after they've taken them for a while. So the complications of reflux, if you don't do something about it, can be serious. Mouth ulcers, pain in the mouth, loss of taste, sinusitis, earaches, asthma, cancer, erosion of tooth enamel. Erosion to the tooth enamel is permanent. Most people with GERD have erosion of tooth enamel. The worse the reflux, the worse the loss of enamel. Obesity is a major cause. One of the reasons is the weight of additional fat on the stomach can weaken the sphincter. Poor diet, food sensitivities, and real common ones are milk, gluten, sugar, coffee, alcohol, fruit juices, onions, chocolate, fat, and fermented foods. Now, most people can just convert to a plant-based diet, and they don't have to worry about other triggers. Excuse me. But if that doesn't completely solve the problem, then we start looking at these other potential triggers. Another problem is fast eating and not chewing food well. We have gotten into eating fast in our country, first of all, because we don't take the time to eat. And the second thing is because we eat food while we're driving, we eat food while we're doing other things and just kind of inhale it. We miss the whole point. Don't even taste our food a lot of times. One interesting thing that I'll share with you is that for some people who seem to have difficulty stopping binge eating and overeating and all that sort of thing, one of the things I tell them to do is I just want you to start when you go home. If this affects all of you, I think it'll help you, or any of you rather. Go home, and what I want you to do is I want you to really slow down and eat as much as you want. Like if you want to eat all 12 donuts, you go ahead and do that, all right? But I want you to sit there and just eat the donuts and experience the eating of the donuts and chew them up really well and swallow them and just experience the joy of eating a dozen donuts. And you know what happens to people? They come back in and I'll say, how'd it go? They go, oh my gosh, that was awful. I mean, after I ate 4, I couldn't stand it anymore. My stomach was hurting, you know, or they'll say I'm so disgusted with myself. In other words, a lot of our really terrible eating habits result from mindlessness, just mindless chomping away on stuff and not paying any attention. And it's astounding what happens when you start becoming mindful about it. Another problem that can bring on reflux is liquids consumed with meals. And I'll tell you why that becomes a problem. The first thing is that there's only so much room in the stomach, and in an attempt to eat enough food to satisfy your calorie needs, if the stomach is full of liquid, then you end up eating too much, or drinking and eating to collectively too much, and the stomach becomes distended, and that puts pressure on the esophageal sphincter. Constipation is a factor in most cases. It pushes the stomach up into the up and puts pressure on the esophageal sphincter. Dairy products are a major factor, mainly because dairy products are constipating, along with everything else. Have you noticed how many times we've talked about dairy products being bad for you up here? It's like a special class of bad animal food, right? High fat intake. In fact, researchers infused saline or fat into the duodenum of patients, and fat increased the number of LES relaxations. Saline did not. Research shows that reflux will get worse during the 3 hours after eating a high-fat meal. In other words, what most people will tell you is that it persists. It's not just right after they eat. That's why they end up taking drugs, because it doesn't go away right away. Most people can stand to be uncomfortable for a few minutes, but they can't stand it for 3 or 4 hours. Overeating, even without liquid, the tension of the stomach stretches the sphincter until it's pulled open, allowing gases and acid up into the esophagus. Researchers inflated balloons in the stomachs of subjects, and that increased the number of relaxations. So it doesn't have to be full of food, it just has to be full in order to cause that to be weakened. The pain is more frequent for smokers and those who drink coffee after meals. Raw onions can sometimes be an issue. People don't have the same response to cooked onions. But again, once you convert to a plant-based diet, if you don't get all the way better, then you would look at food triggers like raw onions. Coffee in some people. Decaf coffee doesn't really make much of a difference, which means that it's probably something else in the coffee bean that's causing it. Now, to be clear, coffee doesn't cause heartburn in a lot of people. But for people who it does cause reflux, then you got to stop drinking it. Chocolate, tomato and orange juice, alcohol, again, not in everybody, but if you convert to a health-promoting plant-based diet based on the pyramid I showed you yesterday, and the reflux persists, then we're going to take a look at some of these things. High levels of H. pylori, but not as much as you might think. And the eradication of H. pylori brings with it a series of health risks. In other words, if the population is too high, we should be reducing it, but the goal seems to be eliminating it. And we've eliminated H. pylori in the guts and stomachs of 94% of people born after 1990. And we know that it's a factor that contributes to increased risk of things like Crohn's and colitis and reflux. Stress definitely has an effect. And then certain prescription drugs. So one of the first things we do when people come into our office is we look at the prescription drugs that they're taking and see if that's what's causing the problem. Okay. Now, it doesn't mean that I'm not going to say something to somebody who's eating a diet based on meat, dairy, and processed foods that they shouldn't change it. But the point is that if the person really works hard to change their diet and continues to take, Valium, for example, they may find that their reflux doesn't get better and can't get better until they get off that drug. So you always have to look at drug interactions, and that's why when some of you ask me questions about, this is my condition, what should I do? And I don't mean to sound like I'm incompetent when I say I don't know, but I don't know unless I have all the information what you should do. And I certainly don't want to mislead people by trying to give them simplistic answers to their questions when the issue might be a little bit more complicated. I mentioned that asthma was an issue. Acid that reaches the back of the throat can be inhaled into the bronchial airways and burn them, and in response, the airways constrict, swell, and mucus production increases. We see activation of the mast cells and mucus production increases. It's estimated that 80% of all people with asthma also have reflux. Most children with asthma have reflux. And this is interesting. Reflux drugs will reduce the incidence and severity of asthma attacks. So we know there's a connection. Now, how you deal with this, asthma or reflux, is not to take drugs, obviously, but it confirms the fact that there's a connection. Complications of reflux: ulcers, cancer, erosion of tooth enamel, hoarseness, diminished sense of taste, sinusitis, ear pain, and inflammation. Now, there's a type of reflux that we call it silent reflux that you might have heard about. Symptoms are different than GERD, and it's often not diagnosed as a result. It's due to acid reaching the back of the throat or nasal airway, causing intense inflammation. It's more common in infants since they have undeveloped sphincters and they're prone much of the time. The symptoms in infants and children are hoarseness, chronic cough, trouble feeding, spitting up food, delayed weight gain. In adults, the symptoms are things like bitter taste, excessive throat clearing, persistent cough, hoarseness, a lump in the throat that can't be swallowed, mucus in the throat, trouble swallowing, and persistent sore throat. The complications of having it include recurrent ear infections, buildup of fluid in the middle ear, scarring of the throat, and cancer. The American Gastroenterological Association recommends against the use of acid suppression therapy, but gastroenterologists prescribe these drugs all the time anyway, if the person doesn't have typical GERD symptoms. The reason is acid suppression doesn't address the other causes, which include pepsin, bile salts, and bacteria. Well, let's talk about pepsin for a minute. It's a pancreatic enzyme that digests protein, and it's particularly harmful. Remains in the laryngeal epithelia after reflux erupts. The action of pepsin is independent of the pH of the fluid refluxed. So what would cause your body to have abnormal levels of the enzyme pepsin? Protein loading, okay? So protein is a major cause of excessive protein intake is a major cause of reflux. And then bile salts. Why would bile salts, what would diet have to do with that? Well, the more fat you eat, the more bile your liver has to produce to emulsify it. So this is a diet-induced disease most of the time, including silent reflux. The diagnosis of silent reflux is difficult. 80% of healthy controls have some signs of laryngeal irritation, and the diagnosis is highly subjective. There is no accepted protocol for the most effective treatment of patients with silent reflux. Placebo-controlled clinical trials show no benefit for using proton pump inhibitors, but they're prescribed anyway. So in the absence of that, I think it would be a good idea to look at dietary change. If the other stuff doesn't work, how about we change the diet, right? Again, the reason I spend time on this stuff is to show you clearly that your best option is to pay attention to the way you're living your life instead of paying attention to how many specialists you can go see looking for answers to your condition. So medications for GERD, antacids, those would be like Tums, Rolaids, Maalox. They reduce the amount of acid in the stomach. Then you have H2 receptor antagonists like Tagamet, Zantac. pepsid, acid. Histamine stimulates the secretion of gastric acid by acting on these receptors, which are found in the parietal cells of the gastric mucosa. And so the H2 receptor agonists block the action of histamine. Proton pump inhibitors, the real popular ones, Prevacid and Prilosec, they reduce gastric acid production. Many antacids contain aluminum, which we know accumulates in the brain and can increase the risk of Alzheimer's disease. Another thing is that gastric acid is needed to break down and digest food. The problem with acid is not usually that your stomach is producing too much. It's really the sphincter is allowing passage of even a single drop of acid into the esophageal tube is incredibly painful. To the extent that you do produce too much acid, it's usually in response to consuming too much protein. And some meds to treat GERD may actually increase the risk of stomach cancer because you create a very unsafe environment when the pH of the stomach gets too high. Two of the most popular proton pump inhibitors are Prilosec OTC and Prevacid. There's an increased risk of intestinal infections, especially C. diff. Taking the drugs can cause negative changes in the gut microbiome, and that allows the proliferation of C. diff. Another condition that results from taking these types of drugs is hypomagnesemia, which usually requires hospitalization. Taking magnesium supplements while taking the PPIs, that's sometimes the holistic pharmacist approach. It's not a very good idea. It doesn't really help. And there's an increased risk of malignant esophageal cancers due to the reduced stomach acid. Results from pancreatic enzymes that should have been inactivated by the stomach acid, damaging tissues in the esophagus. So normally all that pepsin that would be used to digest protein isn't broken down very well when you're taking a PPI. So you're eating a diet that causes you to have GERD. You take a drug that reduces the production of acid, which makes the profound negative effects of the bad diet you are eating more pronounced. Does everybody understand that? This is the downward cycle of give me a symptom, I'll give you a drug, and then you go home and eat, drink, and be merry and wait till the next bad thing happens. Now we have to break that cycle. We just have to break that cycle. People have got to start seeking health instead of sick care treatment. I loved what Dr. Williams said yesterday during the panel when he said he wants to not be in the sick care business anymore. He'd like to be in the health care business. I think that's what we all would aspire to do. So I just wrote a 5-page paper on proton pump inhibitors with about 40 references and their side effects. This is just all about the side effects of the drugs. And so you can go home and watch my lecture on this on YouTube. It's 15 minutes just on negative effects of PPIs, all right? So the causes of GERD may have been a little bit misunderstood, and I think this is really important too. Instead of resulting from gastric acid burning the mucosa of the esophagus, GERD stimulates the release of inflammatory cytokines from esophageal cells, which attracts more inflammatory cells to the esophagus. That's generalized state of inflammation that people exist in because they carry extra weight, they eat an inflammatory diet, and their immune systems are out of control. Inflammation and subsequent damage to the esophageal tissue may be the cause of heartburn and chest pain. If that's true, our current approach to treating GERD can't help at all. Because if you don't do something about the generalized inflammation, you can't possibly solve the problem. And this goes to, Dr. Campbell talks a lot about holism with a WH. It goes to the importance of looking at the whole person when you're considering how to help a person improve their health. You can't compartmentalize. And that's what's happened a lot in medicine, is that we're compartmentalizing. Everybody specializes in a body part. And so you go from doctor to doctor, and nobody's really paying attention to the entire you. And where this kind of, the light bulb went on in my head, I do a lot of professional mentoring with health professionals to teach them how to look at people's health histories and analyze what's been going on and talk to them about their whole health. And I'll never forget, when I first started doing this a few years ago, a doc in my class said, I bet this is the first time, because we make people give us all this information, I bet this is the first time that all of this information has ever been in one place in a sequential order, like what happened to this person, so that we could look at how to help the person unravel the story, working backwards to unravel all the stuff that's been done to him over the years. I think that's so important. So we're big believers in practicing holism. So once again, if you understand the drugs can't help you and all that stuff, where does that leave us? We're back to diet again, aren't we? Dietary excellence, a wellness form health style diet. If you want to resolve this problem naturally. Start with a low-fat, plant-based diet, and then you do elimination of additional foods if necessary. A lot of people get well just by losing weight and adopting a health-promoting diet. If not, you may have to look at specific foods that tend to trigger. Some people are fine as long as they don't have alcohol. I had a guy in my office the other day who was suffering from terrible reflux. Even the PPIs weren't making things better. And he said, I got to the place where I was really feeling good, and I had one glass of wine, and I was miserable. Apparently, I can't have wine. I said, well, that was an interesting experiment, and now you know, all right? Other people can have wine, no problem. So a little bit of experimentation sometimes to find those food triggers. Eat smaller meals. We have a variety of reasons why we recommend that people eat 5 or 6 meals a day. And I'm teaching a course on sports nutrition, which is interesting. And one of the things I found is a tremendous amount of research showing that, because the timing of food becomes important for athletes. That's why I started looking into this. And there's a ton of research out there showing that body composition is better if you eat frequently throughout the day. The amount of calories you burn is better, and actually reflux gets better when people eat less food more often. We call it the eat less more often ELMO diet. It's kind of a good approach to follow. Stop consuming water and other liquids with meals. Consume water in between meals. Dehydration is a common cause, and in fact, in several studies, just drinking more water has been shown to resolve GERD, and it comes out better than PPIs in a direct comparison. Constipation is a cause of reflux, and again, you can have that moving experience by eating a high-fiber diet, and that will no longer be a problem for you. Probiotics are helpful in resolving GERD. And then there are a couple of things, and I debated about whether or not to say this from the stage because I don't like to do this because there's so many caveats, but DGL is a chewable, you can get it in a chewable form, and it can sometimes help people wean themselves off of PPIs because it coats the esophagus and prevents pain. It's contraindicated for some people, so the decision to use this should be made with a health professional. And then slippery elm bark tea is also helpful for relieving pain and discomfort during the withdrawal process from PPIs. So let's move on and talk about gallbladder disease. And another bad development, I think, in medicine has been this cavalier attitude that if a body part's giving you trouble, we just take it out. They're very cavalier about removing body parts, and I think you should hang on to your body parts, as many of them as you possibly can. So in spite of that, there are 800,000 hospitalizations a year for gallbladder disease, and most people have some gallstones. They don't necessarily cause problems. Women are more likely than men to develop them. 50% of women over age 70 have some. A gallbladder attack, which you probably have heard of, leads to hospitalization, trips to the ER. This is when the cystic duct, which carries bile to the small intestine, becomes blocked. It causes incredible pain in the mid-upper or right upper section of the abdomen, can involve the right shoulder. It can radiate all the way up to the shoulder. Nausea and vomiting are common. It can last for up to 6 hours. Inflammation and bacterial infection can result. The treatment is antibiotics and removal of the gallbladder, and it almost always occurs again if you don't do something about the underlying cause. So what the cycle will usually be is a couple of gallbladder attacks and then the advice to remove the gallbladder because there's nothing you can do about it. Well, there's a lot that you can do about it. More than 90% of gallstones in westernized countries have high cholesterol content. Well, where's the cholesterol coming from, folks? It's not coming from broccoli. Let me give you a clue. When bile fluids in the gallbladder become oversaturated with cholesterol, solid crystals form, which can eventually develop into stones. Diets high in cholesterol-containing foods, main cause of this. A diet high in the intake of plant fat can also cause it because the liver produces more cholesterol-containing bile. And this is why you hear people like Dr. Esselstyn talking about the fact that you can't eat a high-fat diet and replace plant fat for animal fat and end up improving your health. First of all, you're not going to lose weight that way, most of you, by continuing to eat this calorie-dense food. And something I think needs to be said about this, and I talked about it a little bit yesterday, but a cup of avocado has 21 grams of fat. A tablespoon of oil has 120 calories and 14 grams of fat. People eat 50 grams of fat on their salad and then say, I can't understand why the weight won't come off. And my cholesterol is still high. Gosh, I wonder why. So the substitution of plant fat for animal fat is not a good idea. I'm not suggesting that people never have fat at all, but I'm suggesting that if you're eating oil and avocado and nuts and a lot of those foods with a lot of regularity, you're going to have trouble with weight and you're going to have trouble with health. This is evidenced here. A low-fiber diet contributes to gallstones because slow movement of the contents through the intestines results in reabsorption of some of the bile acids. A high-fiber, low-fat diet helps to prevent gallstones. There's a direct relationship between the amount of fat in the diet and gallstone formation. So I mentioned most people have some gallstones, and most of the time they don't cause pain or symptoms, and they're often discovered by accident when getting an image for something else. 80% of the time they can be left alone, and they're best left alone because the risk of surgeries sometimes, most of the time, outweighs the benefits of removal in asymptomatic people. People who are diagnosed accidentally, however, are often told incorrectly by their doctors that this will develop into cancer if they don't have their gallbladder taken out. You want to avoid surgery for gallbladder if at all possible, and here's the reason why. When the gallbladder is removed, there's no storage area for bile acids, which means that the bile acids drip directly into the large intestine. This can cause irritation, diarrhea, and increase the risk of colon cancer. Here's the other thing. 35 to 40% of the time taking the gallbladder out doesn't change the symptoms at all. And I have a friend who had his gallbladder taken out because his physician advised him to, and he is just as uncomfortable today as he was the day before he had that operation. And it hasn't gone away. In fact, it gets worse. The risk of cancer on the right side of the colon is higher for people who've had their gallbladder removed. Remember, that's the hardest place to get an image. So this is a great way to end up with colon cancer. An optimal plant-based diet, very low in fat, can resolve gallbladder disease and eliminate the need for surgery most of the time. In fact, one of the things that we'll sometimes do is when people are scheduled for gallbladder surgery and call and say, I'm getting ready for surgery, what should I do to make sure this doesn't happen again? And I'll say, well, why don't we do this? I know your surgery is scheduled for 2 weeks from now, so how about we adopt a really low fat, plant-based diet? A good portion of the time people cancel the surgery because they're completely asymptomatic within a short period of time. And I love people with gallbladder disease, and I'll tell you why. They only have to eat one high-fat meal, and they're back to being in excruciating pain, and they never do it again. They are among the most compliant patients. And you remember I mentioned yesterday about the flaw in the design of humans where your arteries don't have any nerve endings, so you can abuse yourself for a long time? Isn't that a shame? Because if there was some big warning sign every time you ate something horrible, we wouldn't have to have conferences to talk about this anymore, would we? Because everybody would get the warning sign. Just like you put your hand on a hot stove one time, you don't do that again on purpose, right? Okay. So that's why we have to approach this from an intellectual standpoint. I've talked to a few of you in between sessions and that sort of thing, and I enjoy that kind of dialogue a lot. But I try to talk you out of this idea that you're going to see how you feel after eating things. A lot of the people in my office didn't feel bad at all after eating a lot of high-fat food until one day their gallbladder started screaming at them, and then they know that they have a problem. So you've got to look at this from an intellectual standpoint and start making your decisions based on what makes sense. All right, so the last thing we're going to cover is Crohn's disease, colitis, and ulcerative colitis. And the last time I did this conference, I talked about this, but it has become such a common condition, I think we have to talk about it a little bit. So it's a severe form. These are severe forms of inflammatory bowel disease. They affect different parts of the GI tract, but the causes are the same and the solutions are the same. The principal dietary issues are dairy, gluten, animal protein, and fat. Sulfur compounds in animal foods are a factor just like they are in the development of polyps and colon cancer because of hydrogen sulfate, which irritates the colon. It affects about 1.4 million people in the United States, costs $1.7 billion a year. One hypothesis about Crohn's and colitis is Jahn's disease was discovered 90 years ago in Germany, caused by a mycobacterium similar to the one that causes TB. It's called MAP. It produces the same symptoms of Crohn's disease in cattle as Crohn's in humans. According to the National Animal Health Monitoring System, 22% of Americans' dairy herds are infected with MAP. According to the USDA, the infection rate is higher, 68.1%. Infected cows shed the bacteria into milk, which avoids pasteurization. survives that. Scientists at St. George Hospital in London found MAP in 92% of the intestinal tissue samples taken from Crohn's patients. Crohn's is more prevalent in countries in which dairy consumption is higher, and you see lots of references here. We don't have any Esselstyn-type data studies on Crohn's and colitis, but again, if you start connecting the dots by looking at lots of research studies, a very clear picture starts to emerge. The incidence of IBD varies by geography. People living in Asian countries have historically had low rates of IBD, but it's increasing rapidly because Asian countries are catching up with us in terms of our eating habits, which they covet for some strange reason. They want to be like us in that way. So it's likely that an environmental factor like diet and lifestyle would be the reason if it changes by geography. Migration studies show that when people move from one area of the world with low IBD rates to the United States, they catch up pretty quickly, about 15 years. Diet high in meat, high-fat foods, and desserts has been associated with a higher incidence of Crohn's disease in children. Higher intake of refined foods is shown to increase the risk of Crohn's and ulcerative colitis. Higher protein intake significantly increases the risk of ulcerative colitis. One thing I hope you're noticing as all of us get up here and give these presentations is how much the same diet, same bad diet, wreaks havoc with the body. It's just what havoc it wreaks in your particular body. And that's where genetics comes in, by the way. Genetics isn't the cause of the disease. It's which disease you're going to get if you misbehave. All right, that's really what it's all about. High intake of meat, particularly processed meat, protein, sulfur and sulfate, alcohol, associated with relapse for ulcerative colitis patients. They often don't put this together because they're eating enough bad stuff that they don't really see much change. Animal foods, especially dairy products and eggs, are high in sulfur, and sulfur can damage the intestinal lining. That's the cause of the polyps. Cow's milk products negatively affect colonic epithelial cells by increasing inflammation. That's a known marker for IBD. One study showed that when dairy was removed from the diet, patients showed clinical improvement. When it was reintroduced, 100% of the patients went back to having severe symptoms again. Everybody got better, and then everybody got worse. It doesn't get much more clear than that. A review of 19 studies, including over 2,600 patients with IBD, diets high in total fats, polyunsaturated fats, omega-6 fatty acids, and meat were associated with a higher risk of IBD. Diets higher in fiber and fruit, associated with lower incidence of Crohn's disease. Diets higher in vegetables, associated with decreased risk. So you see the trend? Individual studies looking at individual data points, but all pointing essentially in the same direction of what we've been talking about since you guys have been here. 30 newly diagnosed patients with Crohn's disease were interviewed about their pre-illness diet and compared with 30 healthy controls, and here's what they found. Crohn's patients ate substantially more refined sugar, less dietary fiber, significantly less raw fruit and vegetables than controls. You eat animal food and processed foods, you eat enough of those things, you're going to get sick. Which illness? That depends on your genetic profile. You heard me say yesterday, if I start misbehaving, I get rheumatoid arthritis. Somebody in the fourth row gets diabetes. Somebody in the back of the room develops cancer. That's where genes come into play, all driven by the same habits. And the other thing, by the way, I want to mention to you about genes, because I think this is important, you can have a great genetic profile. No disease really runs in your family. Everybody lives to be 100. You misbehave enough, and you can override your good genetic profile and induce disease. Okay? It's really up to you. We get the control. A study in Japan looked at the relationship between dietary changes and incidence of Crohn's disease. Increased intake of total fat, animal fat, polyunsaturated fat, and milk protein was associated with increased risk of Crohn's disease. The strongest independent dietary factor, animal protein. Second most was increased intake of polyunsaturated fat. So you see why you can't just eat a lot of plant fat instead of animal fat and end up having a healthy body. Fat is fat is fat is fat is fat, and when it gets too high, when intake gets too high, you're going to end up with health issues. So all you folks out there eating avocado toast, think again, all right? I love it too. By the way, just so you know, I love all this bad stuff too, all right? I don't have it in my house, so I don't play willpower games with myself in the kitchen. I've said this many times that adhering to this diet, doing the right things, isn't a matter of willpower. It's a matter of setting up your environment so that you can only make good choices, and it's a lot of work to make the bad ones. I get up at 5 o'clock in the morning. I'm not going to Kroger at 5 o'clock in the morning to get avocado for toast, I'm telling you. So you know what I end up having? Fat-free hummus on the toast, because that's what's in the fridge. all right? Patients who eat less fiber, less raw fruits and vegetables, more refined sugar, have an increased risk of developing Crohn's disease. See the pattern here? Study of Canadian children eating more vegetables, fruit, fish, and fiber reduced the risk of Crohn's disease, increased intake of omega-6 fatty acids. Where do you get that? Land animals and polyunsaturated oils, that plant fat showing up there again. 101 patients and 143 healthy controls, bread, butter, margarine, cheese, meats, ham, and sausage, increased risk of UC. Okay? So let's talk about diet for a minute. And before I tell you about diet, I just want to give you some context. So I was approached shortly after I went into business with a person who had Crohn's disease. She had it for 20 years. She was spending about 6 weeks of every year in the hospital because it was a pretty intractable disease. And she was bleeding out, taking Remicade, which is a drug used to treat Crohn's patients. And she had developed a lump in her breast. She had a spot on her lung and an abnormal Pap test. And she said, I don't know if the Crohn's disease is going to kill me or if the drugs are going to kill me. So I started looking into all of this. That's when I found all this type of information that I've been showing you little excerpts from. And I started looking at what they do for Crohn's patients. And the first thing is this elemental diet is often used for flare-ups. It's fortified liquid diets designed to rest the GI system, contains vitamins, minerals, and amino acids. And I started thinking to myself, fortified water doesn't sound much like a treatment. What if it's what's not in it? Okay, what's not in fortified water? A lot of protein and fat. So I was able to find another study that was a comparison of Crohn's patients using elemental formulas with no intact protein to patients using formula with intact milk protein. The remission was achieved in only 36% of those using the intact protein formula versus 75% and those using no intact protein. So this elemental diet works for a while, but it's not practical for long-term use. But the research that I looked at showed clearly people aren't getting better because they're drinking vitamin water or having vitamin water. They're getting better because they're not eating so much protein and fat. So then I thought, well, what else can we find out about Crohn's patients? Well, 32 Crohn's patients and 32 matched controls. Intervention group, unrefined high carbohydrate diet in addition to traditional treatment, all followed for 4 years and 4 months. Patients in the intervention group spent 111 days in the hospital, 533 days average for the control group. That's a pretty big difference. 5 of the control patients had surgery, 1 of the intervention patients did. Researchers concluded that the outcome of the diet-treated patients was in strong contrast to general experience with this disease, no kidding, and that treatment with a high-fiber diet consisting of unrefined foods appeared to lead to positive outcomes for Crohn's patients without leading to intestinal obstruction. Interesting, right? Fat reduction is beneficial for Crohn's patients following small bowel resection. One study showed a low-fat diet resulted in significant reduction in the amount of water and sodium excreted with bowel movements. 10 out of 13 patients began having solid bowel movements. Study with 33 patients, 29 were able to identify food triggers. And this is another thing you see constantly in the literature, the published studies on Crohn's and colitis patients, is that when asked, almost all the patients can point to triggers they've already identified. And you know, the Crohn's and Colitis Foundation has on their website that diet has nothing to do with this, that it's essentially the imagination of Crohn's and colitis patients that they think that their diet is causing this disease. Exclusion diets have been shown to improve IBD symptoms. Patients just on an exclusion diet remained asymptomatic for 6 months. Going on to the next slide, exclusion diets have in fact been proven to be more effective than drugs. One study, remission of symptoms for 5 months in a group taking corticosteroids, 15.3 months in the diet group. Most common food intolerance, cereals, dairy products, and yeast. Crohn's patients had higher IgG antibodies against processed cheese and yeast. Restriction resulted in an 11% decrease in bowel movements, reduction in abdominal pain, improved well-being. Twice as many patients eating a milk-free diet were symptom-free during one trial as opposed to those eating a traditional diet. So you guys seeing a pattern here? It's all kind of pointing the same direction, yeah? Outcomes are better when healthier dietary patterns are combined with the elimination of trigger foods, and this is very important. 20 patients with Crohn's disease were assigned to eat a diet on unrefined high carbohydrates, high fiber diet, or a diet that excluded specific foods to which the patients were intolerant. 7 out of 10 patients on the exclusion diet achieved remission for 6 months. None of the 10 patients eating the unrefined carbohydrate diet without exclusions achieved remission. And so this goes to the fact that treating an IBD patient involves further food restriction than treating somebody who has cardiovascular disease. And so if all of the Crohn's patients started eating Dr. Esselstyn's diet, they wouldn't really get much better, because if they continue to eat the trigger foods, they would continue to trigger the symptoms. Gluten restriction. I was able to find several hundred studies that showed that this works, either self-reported data, case reports, or research that actually showed an intervention. 2003, this is the closest thing I could find to a study like what we might like to see with a dietary pattern. 22 adults in remission, either medically or surgically from Crohn's, who consumed semi-vegetarian diet during their hospitalization, were told to continue their diets and avoid foods known to be triggers, and those would be sweets, margarine, fast food, juices, cheese, and bread. They were evaluated after 2 years. Compliance with the diet was 73%. Remission was achieved by 94% of the compliant patients, and C-reactive protein measurements of inflammation were reduced. So 94% is a pretty big number. Leaky gut is common. We talked about this with autoimmune disease, and Crohn's and colitis. IBD is an autoimmune disease. So probiotics, if you look at the data, there are negative changes in the microbiome for people who develop IBD, and therefore probiotics as treatment are recommended. And one of the reasons is there's a known connection between changes in the microbiome and inflammation. Inflammation fuels the progression of Crohn's and colitis. So what we did after I found all this information is I tried to look at how could we distill all of this into a protocol that might help a Crohn's patient or a colitis patient. So the woman I was telling you about, who I was trying to help, I was pretty honest with her up front. I said, I never did this before, so this is going to be an interesting adventure. And she went to her doctor. I came up with a plan. We are better at the plan right now because we had a lot of practice, but I came up with a plan. She went to her doctor, marvelous gastroenterologist, who said, you've been getting worse for a long time, and obviously what we're doing isn't working. How about we stop drugs and see if this works? You can always take more drugs later. Don't you love a doctor like that, right? So anyway, she went off her drugs, and I'm going to show you what we did. It was kind of like this, but like I said, we're a lot better. We've had a lot of years of practice now. So the first thing is we put people on a bland cooked food diet. And the reason is we're mimicking the elemental diet. Remember, what's missing in the elemental diet is protein and fat. So these patients can eat any kind of potatoes, brown rice. Brown rice reduces diarrhea, so it's a good food to eat if you're having 20 bowel movements a day. Steamed vegetables, but only 4. Peas, green beans, carrots, celery, squash, any type, well-cooked fruit. The thing that this has in common, these foods have in common, is that they're very low-fat, low-protein foods. What you can't have, no dairy, no high-gluten foods, which are barley, rye, oats, and wheat, continuation of our discussion yesterday. No oil, no raw vegetables, no supplements, no juice, no refined foods, no beans, no grains other than brown rice, no spices other than salt, no beverages other than water. When the patients call and say, can I have chamomile tea? What part of the no beverages other than water didn't you understand, right? Well, English translation is no beverages other than water. All right. They're also instructed to eliminate any food that causes a problem. So once in a while you have somebody who says celery doesn't work for me. Once we get somebody to the place where they're having solid bowel movements, we introduce probiotic therapy. Then we start expanding the food options, and we have a very specific schedule for all of this, which food goes next, and we give people a manual. It's got a lot of this stuff in it. It has an instruction letter for doctors and that sort of thing. We start increasing the probiotics and increasing the doses, changing up the type. And then maintenance is no dairy, no high gluten foods, low fat, low sugar, small quantities of legumes, raw cruciferous vegetables. Avoid overeating, and stress can be a trigger. So there's lots more to it. I mean, my IBD training program for docs takes many, many hours, all right, but I'm giving you the summary. So I'm going to show you, this is from one of my folks, Carrie. Even though I was on medication for Crohn's disease, I still had frequent symptoms. At 30 years of age, this disease seemed to take over my life. I found myself not doing things I once enjoyed. My life revolved around the restroom. And when I went somewhere with my kids, they would see one and tell me where it was in case I needed it. I stopped making plans with friends. As a single parent, I was afraid of losing my job because of all the frequent restroom trips I was having to make. Living my life now has become more worry-free. I can make plans with friends and family and go places with my kids. It's nice not to worry about where the closest restroom is or even if I'll make it on time. A great example of change, I used to love riding on the back of my friend's motorcycle, but when the Crohn's took over my life, I was afraid to ride anymore. I even sold all my riding clothes because I thought I would never be able to ride again. But now I date somebody who rides and I'm always going on trips with him. Crohn's disease no longer controls my life. So we've had an opportunity over the years to practice. In fact, after that first person got well, who was still well, 18 years in remission, which is unheard of, no drugs, and all of her other markers are great. She's got low cholesterol, normal weight, the whole 9 yards. I said, if there's a God, you'll send me some more people to practice on because I really could get good at this if I had some more people. And we got a ton of them. We got many, many people who came. And over the years, we got to perfecting this protocol so that we can say that most people, not all, but most people can achieve remission and remain in remission if they follow this protocol. So in summary, gastrointestinal discomfort and disease is almost always related to poor eating habits. Supplements and drugs will relieve discomfort, but they don't address the underlying cause. And diet and lifestyle change, weight loss, improving your health, that's the actual solution to all these problems that aren't as intractable as they seem, including Crohn's and colitis. So I'm happy to take some questions. I managed to finish this so we could have a lot of time for questions. Thank you. All right, who has a question? Yes. Are we going to have a microphone? Oh, here she comes. Right up here.
Thank you so much for your talk. I was wondering, are there different kinds of probiotic for different conditions? For example, like skin disease? Is there something else?
Yeah, we were talking about this before with a couple of us. There was no way in this time period that I could go into specific protocols and what to use. This is where you really do need to work with somebody who understands probiotics. And so a really high dose probiotic, for example, with a Crohn's patient who's bleeding out, would be devastating and make things worse instead of better. So you do have to match the probiotic with the person, then you have to change them up over time, and that sort of thing. So yeah, there's a whole science to that too. I have not written a book on this topic, and so you just have to read the medical literature. There's so much in the medical literature, and I would like to write more books, but it's difficult. It takes a lot of time. So instead, what we do is we create educational programming. We have 3,500 hours of programming at our company, and we have about 2,500 plus articles, like the ones I've mentioned about proton pump inhibitors and that sort of thing. And so we think that that's the easiest way to distill this in for consumers. So consumers who have these types of issues, that's one of the reasons they join Wellness Forum Health, is to have access to this type of data. And they know it's been really well vetted. Yeah, let's take this one.
Hi, Doctor. We enjoy your lecture very much. So.
Thank you.
And I would like to see your diet on a daily basis, let's say.
Okay. Well, first of all, I want to say I'm happy to tell you what I eat on a daily basis. I haven't necessarily been able to do exactly this here because of the time, but when I'm in my natural environment at home, the first thing I'll tell you is I don't have to worry about the cost of food, which is an issue. And the second thing is I live a mile from my office and I can go back and forth, and I own a food service operation. So I just want you to keep that in mind, all right? Because it facilitates my being able to do some things. But I'll start by telling you when I'm home, like if I'd been home this morning, I go to the farmer's market on Saturday. And I buy as much produce as I can there. It's cheaper, by the way, and I like buying food from people who grow it. I like to support local farmers. The amount of food that I buy is pretty amazing. Like people are always asking me, are you a caterer? And I tell them, no, I will be eating all of this food by next week, and then I'll be back to buy more. And they go, wow, for a little girl, you really do eat a lot of food. I tell them, you have no idea. All right. So, and then the other thing, as soon as I go to the farmer's market, I have 3 places that I go for other stuff. Like I go to Trader Joe's and I go to a place called Meijer. It's a big superstore. Go to Kroger. And I don't go to all those places every week, but I rotate. Like every 3rd week I get to one of those places. And I buy other stuff you got to have, like salad dressings and that kind of thing. Okay, then I do a lot of batch cooking on Sunday because my day starts at 5 in the morning. Monday through Thursday, it ends at 11 o'clock at night. And then on Saturday, it starts at 5 in the morning, and maybe I'm finished at 5 or 6. All right, so no time to cook. So here's the deal. I get up in the morning, and I make a smoothie that our company makes the ingredients for. I have 2 pieces of Ezekiel bread toast with fat-free hummus. And then that carries me through. It's deliberately a whole bunch of food because I need to get through my whatever I'm going to do for exercise in the morning. It's either running or a gym workout or going to hot yoga or something of that nature. All right, so at 11 o'clock, I eat lunch. And I make a salad, and it's sort of like, think about salad for 6, only I'm going to eat all of it, all right? And then I'm going to have something with it, like sweet potatoes or black bean chili or vegetable wraps or something that has sort of a starchy component because I need that calorie density, all right? At 3 o'clock in the afternoon, I have another meal. At 6 o'clock, I have another meal. The 2 big salad meals are lunch and dinner. But I'm eating the things that I batch cooked at all these other meals. And so about 6 o'clock, I'll have another meal, and then I teach till 11 o'clock at night a lot of nights, and at 11, I'm hungry again, so time for more food. And a lot of times at night, one of my guilty pleasures is chocolate-flavored balsamic vinegar, which if you put it in the fridge, it gets syrupy. And so I'll have a big bowl of berries and fruit with that chocolate vinegar, and it's fabulous, really fabulous. So anyway, that's my daily eating pattern. It's big piles of food, big piles of food, okay? Let's take this one over here. Yes, you.
Since everyone here is comfortable talking about bowel movements,
Yes, we are.
I have typically 3 a day, sometimes 4. My question is this too much of a good thing?
No, it's not. The other thing that we should point out is that everybody's not the same. So I find that some people think that having bowel movements is a competitive sport, and there's a certain quota that you must reach, and if you haven't achieved that quota, then there's something wrong with you, but that's not the way that it works. Everybody's a little bit different in that regard. And it can vary day to day. Some days you may eat a lot more fiber than other days, because our diets aren't exactly all the same every single day. So, yes.
I've developed a little bit of a skin problem on my face, a rosacea kind of thing. I don't think that's exactly what it is, but my doctor is telling me to change my diet and to kind of do a lot of what you guys are all talking about. What is the connection with the skin problems and the gut?
The connection with everything in the gut. In other words, your gut bacteria control what gets in your bloodstream, what stays out, controls your immune system. So there isn't a body function. There's nothing that goes on in your body that isn't in part related to the gut. And so often skin conditions are a reflection of what's going on inside, not the localized display of whatever it is. Okay. Let's right back there. Yes, you. And then we'll go back over to this side. I'm trying to be fair. Yeah.
Okay, I'm just curious. You're sharing about your late night snack and about small meals frequently through the day. What about some of the other information that we've heard that that cycle of I don't know technically what it's called, but it's digestion, allowing the body to rest. That truly allowing the body to fast and the breaks in between.
Well, show me the evidence. Remember the Tom Cruise movie? Show me the money. Show me the money. Right?
So
show
you're
me
saying that
show me
there
the
isn't
evidence.
evidence out there?
No. Well, here's the thing. I think this is another one where there's some reason to believe that this is a good idea for certain people with certain conditions. Intermittent fasting, for example, for cancer patients. But I don't really see any evidence showing that a person like me is going to benefit from making it harder for me to be me and do what I do by intermittent fasting. If I saw evidence indicating that would be the case, I would do it. One of the things that I would caution, I touched on this last night if those of you who were here or watching for the panel discussion, is we have got to stop making this so hard for people to do, all right? Sometimes I think we all sit at home and think of the hardest restrictions we can come up with, and can we still get people to get on board and do it? The goal here, if somebody's going to benefit from dietary change, you got to get them to do it for a long time. 20 days of dietary change doesn't change anything for anybody. We got to get people to do this for a long time. And setting up barrier after barrier after barrier to make it hard is not the way to make this happen. So my concern with intermittent fasting is without a lot of evidence to show that it makes a difference, If it's going to make people stop eating a plant-based diet and stick with it, I'd much rather people eat a diet like what I just described to you for 25 years than intermittent fast for 3 weeks and done. Back to cheeseburgers again. You know what I'm saying? So that's what my concern is with it. Not a lot of evidence to show that it makes a difference in the long term. A lot of hypotheses, but we really don't have that evidence. I'm open to looking at it, but we don't have it now. Okay, let's take somebody over here. Yeah, you got it. Okay.
Hello. I was wondering if you could comment on people with the HLA-B27 gene and with the Klebsiella infection, because they say that they cannot consume starches, so they completely do not want to do plant-based at all. It's like
Well,
not even
I
an option.
I disagree with it. I mean,
Thank
that's
you.
the most we'll say right now because it's kind of a technical topic to get into. But you get a lot of people locked in dogma. This goes to, well, I'll back up and say, there are some situations in which dietary, the normal diet for plant-based people should be a little bit different because of very, very specific situations, but this is not one of them. I think this is just people making up more reasons to eat animal food, in my opinion. Okay, somebody else over here since we took two over there. Okay, yes.
I just have a question about the probiotics. I understand that the really good probiotics have to be refrigerated. Is that accurate?
No,
It's
the
not.
biggest thing, the biggest thing with probiotics is that the longer the distance between when they left the factory and when you put the first one in your mouth, the more degradation takes place. So you're better off with an unrefrigerated product 3 weeks from the factory than a refrigerated product where you don't know how long it.
And could I ask you the ratio, or could I ask you which you take yourself, or
Well,
that you recommend?
I don't want it doesn't make any difference because it would not apply necessarily to anybody here. What I'm telling you is that, I said this yesterday, most of the people coming into my office taking a probiotic are taking a product that can't ever help them. So do take the time to find somebody who can help you know what to take so that you actually benefit from the money that you spend. Okay.
And one more, sorry. Alkalized water, is that something also that you advocate?
Absolutely not. In fact, it's
Not?
dangerous, and I'll tell you
Really?
why. Your blood pH has to be between 7.35 and 7.45, period. Goes lower, you're going to die. Goes higher, you're going to die. So you spend a lot of time talking about metabolic acidosis when you eat a diet so high in high acid load foods like animal foods, dairy, processed foods, that your body's constantly struggling to keep your blood pH from dropping under 7.35. Everybody understand that? All right. So your body starts borrowing minerals and like sodium and calcium from the bones. The bones is where your biggest store of calcium is, to buffer the acidity. Bad idea. Everybody agree? Okay. So now you consume this pH water of 8.5 or 9. Your pH can't go over 7.45 in the bloodstream. You're going to die, all right? So now your body's making all kinds of adjustments to keep you from going into alkalosis. And the other thing too, people think they're going to alkalize their body. You better pray that never happens. You need for the environment in your stomach to be very low pH. You need your blood to be in a specific range. And so this whole idea that you think you're going to alkalize your body is a fantastical idea that is not supported by science.
Okay, thank you.
All right, let's have one in the back. We always ignore the back. You right back there. Thank you.
Doctor, can we get as much bacteria through fermented foods?
No, absolutely not. That's another fantastical idea. Fermented foods do not contain bacteria. If you like sauerkraut, eat it. If you think that eating sauerkraut is going to restore your gut, it can't. Okay? To the extent that sauerkraut can be part of a plant-based eating pattern that supports healthier gut microbiome, that's great. But by itself, it's not a magical food. And so a lot of people have been very misled by, and people, my problem with that is, first of all, it's not true, but the second thing is you find people choking down food they hate because they think it has some magical property. And that's another thing I'm opposed to. I'll never forget, early in my career, I had a conversation with somebody. It was a follow-up conversation. I said, well, how's it going? She goes, it's okay. I said, well, you don't sound very excited. She goes, well, I'm eating green apples. I'm eating kale. I said, well, you don't like green apples or kale? She goes, no. I said, well, then why are you eating them? And I say, I don't like green apples either. All right? I don't eat them. Eat the food in the plant-based world that you like. Make this fun to do. Make it something that you will not mind doing for decades. That's where the benefit comes. Decades. All right. Okay, who's next? All right, we'll take you next. Yeah.
Thank you, Dr. Popper. I wanted to ask you, now I've known of different family members and young kids who've tried different rounds of different medications, and I think we touched upon it yesterday a little bit. But what would you suggest with someone who is trying to go into the route of, with Crohn's disease, trying to get into the route, whether they're young or older, and I know it's very specific for each individual, but how would what can I suggest to them to do besides call you?
Well, that's what you have to do right now. 'Cause
Right.
we're the people who know how to do this.
Right.
And so the key is, and sometimes people say, well, got to talk to somebody in Columbus, and it's going to cost money. How much money does it cost to keep doing what you're doing with dreadful outcome? So we've trained a few practitioners around the country to do this, but unfortunately, we'd like to see this be the standard protocol. It's my dream. We are starting a longitudinal study of Crohn's and colitis patients. A colleague and I are writing up some of my case reports to publish in journals. They're just case reports, but we're going to scientifically document. And then we're going to start a longitudinal study, much like what Dr. Esselstyn did with his cardiac patients. And so we're hoping that will get more attention to this type of thing too. Okay, who else? We'll take you next. Microphone. Hello? Yeah. Oh, okay. Well then, do we have a second microphone? Oh, okay. All right, well then you find somebody else to go next, and that'll lessen the time while you're asking me, okay?
Hi. I wanted to ask, you hear over and over how for your gut health you shouldn't eat, oh my gosh, you shouldn't eat, oh my gosh, yeah. You know what, you had a question.
Take a minute.
You should, I just completely lost
All right,
my
well, I'll
question.
tell you what, we'll take another question, I'll come back to you. All right, yes.
What about our soils being depleted and plant-based supplements?
Our soils have been depleted. I mean, there's no question that farming is not well practiced in this country, and I think at some point in time we're going to have to change it. But this depleted soil thing has become one of the things that has fueled the sale of dietary supplements. Dr. Esselstyn and his amazing results, no dietary supplements. All that bad soil, still growing food that Esselstyn's patients are staying alive on for 30 years. Same thing with John McDougall, same thing with many other practitioners, Neil Barnard and the research that he's publishing. We have no requirements in our Crohn's and colitis program for people to have to eat organic foods or take supplements because the food is not nutritious enough to heal them. So here's what I have to say about this, and we have to make sure that we're not mixing our drinks. If we were having a conference about farming, we'd be talking a lot about what needs to happen in order for farming to be sustainable and to save the planet, yes? There's a conference about human health, and we have to make sure that we're telling people what they need to do in order to improve human health. And so the farming, the bad soil issue doesn't mean that the food that you're getting at your local Kroger store is insufficient for you to be able to heal up and maintain your body.
Do you eat organic?
What's that?
Do you eat organic?
Yes and no. I mean, to the extent that I can, I do. I think the important thing to remember, and I do it, by the way, is not because I think that my health will suffer as much as I would like to support local farmers and sustainable farming. But I don't prescribe organic food for a couple of reasons. It is unaffordable by many people. When a head of cauliflower reaches about $6 or $7, you just knock everybody out of the game. And it's not available everywhere. So we can't set people up to fail at this. And I see a lot of that going on in here. We're setting people up to fail. Let's give them 25 restrictions they can't possibly do for a lifetime, and let's make it so expensive and difficult that nobody will stick with it. That's so counterproductive to what we want to do. You know what people say about me who hang out with me after a while? And when I go someplace new, they say, "You're just like a regular person." Yep, I am. I can eat at the buffet for breakfast this morning. I mean, I am just like a regular person, and I'm pretty health conscious. I mean, I make my living doing this, right? So I'm not out there eating cheeseburgers and French fries on the side when nobody's looking. But the point is that we have to teach people to be able to function everywhere, economically and logistically. Okay. Now, did you think of what you want? Thank you.
What I want to ask is, you hear today about how you should eat gluten-free.
Mm-hmm.
Okay. My question was, should you actually be eating gluten-free
No.
if you
This is-
don't have
no.
any kind
This
of
whole
stomach
issue of
digestion
gluten-free
issues?
has been that we've fanned the flames on this gluten issue. Really, what the impetus has been a lot of quacks, I'll just say it, who told you that gluten's bad for everybody. William Davis and David Perlmutter being the kings of the whole deal. And I think it goes to the fact that Perlmutter and William Davis are celebrated by medical doctors who think that these people have the secret to health. And I'll tell you what, Perlmutter's book, I told you yesterday about Davis's book. We matched up all the references, and his references support what I'm telling you, not what he has to say. And in addition to that, I didn't say this yesterday, we found so many references that weren't even about wheat. He's telling everybody to stop eating wheat. You look at the reference, and we did word searches. You can't even find wheat in the article that he cited. Perlmutter's book was so bad. You know, I own a school, as I told you earlier, and we're pretty rigorous. The students have to really rise to the occasion and learn how to do the research the way I do it. If somebody in my school turned in a paper of as poor quality as Perlmutter's book, Grain Brain, they would be told that they have one more opportunity to turn in an appropriate level of work or they're expelled from school. Okay? This is how bad that book is in terms of the science. So the only good thing that's come out of the stupid gluten thing is that the market for good gluten-free foods has gotten better. So the poor celiac patients who used to eat cardboard don't have to do that anymore, right? So that's the good thing that's come out of it. Thank you. All right. Next question. Who has the mic? Does somebody have the mic? Okay.
I wanted to ask
I think you asked a question before. All right,
No,
we've
I
got a
didn't.
real quick one because we want to get
No, I
every-
didn't.
Oh, okay.
But,
Oh, I'm sorry. Okay.
Getting back to the acid, alkaline, maybe 25 years ago, I heard a doctor saying he was fighting cancer, Ribisi, I think was his name, by creating, cancer can't live in an acid, likes an acid environment, can't live in an alkaline environment. So he was treating cancer that way. So
Yeah.
let me just finish though. Now, at Stony Brook University, I think her name is Dr. Barbara Thompson, maybe. Nature Nurture, she does a lot of research with cancer, trying to get to that whole thing. I might have it wrong, but I asked her that question, and she says she doesn't think so, but she says in an alkaline environment, your immune system can probably work better.
Well, that's ridiculous too.
Okay, so
First
I
of all,
wanna
the
hear your take on it.
cancer can't exist in an alkaline environment. Well, the blood cancers do just fine. Okay. Leukemia did not get the memo on that, all right? They're doing just fine. So this is, again, this simplistic, trying to boil this all down into a soundbite that is just, it's really disappointing and misleading. Okay. Somebody over here. Shouldn't we get somebody on this side? So we're, yeah, right in the back there. We don't get enough people in the back.
I have a newborn baby that's 3 months, and he takes formula, so I wanted a recommendation on a particular probiotic brand that you feel is effective and, you know.
Yeah. See me afterwards. All right. We'll talk about that afterwards. All right. Instead of in front of the group. We'll take a couple more. I know my time's up, but, you know, I'm not ready to stop yet. So, you know, I have the microphone. So here we go. Anybody want to keep going for just a little bit longer? All right, we're going to do it. All right. So how about up here? And then back there.
Hello. So I'm following a lot about all the plant-based diet information for a long time. In this conference, in the beginning, we had the people from Hippocrates, Dr. Brian Clement, and there was another doctor. So he was talking a lot about cancer. There was another doctor, Gabriel something, talking about diabetes, and they both were very pro-raw diet and no fruit, which I feel is very limited. And they both brought like a lot of data to support, which I can't state.
Well,
I wanted to hear your opinion about it.
Well, I haven't seen any data that convinces me, okay? And furthermore, why are we making this so hard? The people in Okinawa never got the message that all the food has to be raw. They eat mostly cooked food. The people in Northern Africa never got the memo you eat only fruit. Okay, so we're making this more difficult than it needs to be. I mean, with all due respect to my colleagues who've spoken at the conference, and I know everybody's trying to do the best to help other people, but I think we do the best to help other people when we make it available to other people, when we make people say, you know what, I could see myself doing that, all right? And I think I could do it for longer than a week. That's the key, right? Well, people who are very sick, once you get them well, they have to stay well for 50 years, all right? So that's, I mean, you bring up a really good point, and it's true that people who are very sick often have to eat more restricted diets. But, you know, I'm going to give you some counter-argument to this. Kelly Turner wrote a book called Radical Remission, and she's the first person who ever did a study of terminal cancer patients to see how they stayed alive. What did they do to stay alive? She interviewed 1,000 of them, not a small number. She was able to identify 75 different strategies used by cancer patients, and 9 that they all used. 1,000 people who didn't know each other all did the same 9 things, all right? And what she found is that cancer patients, first of all, adopt a plant-based diet, but not always vegan. But they did 8 other things in addition that were key to their survival. And one of them was they took a good look at the way that they were living their lives and some of the ways in which their lifestyles outside of the diet may have impacted their illness. And so I remember one guy, he was a kidney cancer patient, terminal, was in the hospital dying, and he was sick from chemotherapy, so he went up to the roof to breathe fresh air, and they thought he was going to kill himself. So the hospital didn't want him to kill himself there, so they sent him home. Wonderful, compassionate approach to health, right? So they sent him home, and basically what happened is he started feeling better and started eating better. And he said he deliberately chose not to practice dietary perfection because he felt that one of the reasons why he had developed cancer was he had been an overachiever, overworker, everything had to be perfect all the time, and that personality trait eventually made him sick, all right? So I think cancer patients should eat well. I think everybody should eat well. But I think sometimes this focus, almost near obsession about, am I doing it right? Am I doing it right? Am I doing it right? Did I eat enough raw? I think that almost becomes counterproductive to a person who's trying to make himself or herself whole again. So let's not practice dietary obsessionism. Let's practice dietary excellence. Those are 2 different things, all right? So did you have a follow-up? Yeah. Or did they shut us off? They're now serious about my getting off the stage.
If I just may add, it just said that his point was that fruit, sugar, including the sugar in fruit, keep the cancer cells growing.
Well, that's a very long discussion, and it's not true. By the way, all carbohydrate eventually becomes glucose or some derivative. So if you're going to try to starve out the cancer, you can eat broccoli instead of strawberries and do it. This is, again, a complete lack of understanding of human function. So, and that doesn't mean that that's where water-only fasting may be appropriate, where intermittent fasting to potentiate chemotherapy. This is a whole other discussion that involves, first of all, understanding how a cancer cell becomes a cancer cell and how the glucose uptake works and how the angiogenesis, and there's a lot of stuff involved in this. So you can't just tell people stop eating fruit because it fuels cancer. This is another one of those fantastical reductionist ideas that represents a complete lack of understanding of the whole etiology of the disease. Okay. All right, who has the mic? Yes, you.
I was just wondering if you could talk a little bit about possibly reversing diverticulosis.
Yeah, well, you have to stop doing the things that cause it: constipation and poor diet. You know, even the AGA's guidelines now say people don't need to stop eating seeds and that sort of thing. Antibiotic treatment's not warranted. So you reverse it by doing the opposite of what caused it. It's a diet-induced disease. So, Steve, are you wanting me to stop pretty soon? One more question, and then I promise I'll hang around. Just so you know, I put out a newsletter every Monday. I put out video clips on Tuesdays and Thursdays. If you'd like to get free information from me, I'll come sit right over here and be happy to talk to you for a while, all right? So one more question. Who has? All right, you got the mic.
I just have a question about, somebody told me that not everyone can do the vegan diet, that her friend was vegan, a man, and he was very overweight, and he went down to like 120 pounds.
Well, nobody taught him how to do it right.
And then he went to see a nutritionist who was supposedly a vegan nutritionist, and she said because he was Celtic origin, he had this gene, and that he should go back to eating meat.
Yeah, so she was an incompetent vegan dietitian.
I mean, that's
right?
not true. That's not true, right?
And I know, one of the things, and I promise the next time I come back, you want me to come back? Okay, next time I come back, I promise I will work on being more direct in my comments, because I know sometimes it's just really hard to figure out what I'm saying. Thank you so much.